I'm Bria Hamlet, and I'm here to talk to you about Louisiana's infant mortality rate, and specifically how health education can save the lives of Louisiana's youngest population. Here you will find the agenda for today's presentation. I will give you an overview of the problem at hand, a slightly more in-depth analysis of the issue, some potential interventions, evaluation plans for said interventions, any barriers that I anticipate, and then a logic model just sort of bring it all together, and of course a bibliography just for a frame of reference. So looking at the problem at hand, health and socioeconomic disparities are fueling high infant mortality rates in the state of Louisiana. So what we know about infant mortality is that it's very heavily impacted by the financial state of the parents, and those parents who cannot afford to bring their babies home to healthy spaces or can't afford really high quality prenatal care are the ones seeing the highest rates of infant mortality in their communities. Marginalized communities are most affected. Those include people of low socioeconomic status, as well as people of color, or people with limited access to health care. Black mothers in Louisiana have the highest incidence of preterm birth, which is a complication that increases risk of infant mortality. Approximately 70% of expectant mothers in Louisiana are also receiving Medicaid services, so that speaks greatly to poverty and socioeconomic status as a leading issue of infant mortality, as well as inadequate prenatal and postnatal care. We also know that in Louisiana, the state is leading with the number of cesarean sections that occur every year, with nearly 40% of all births requiring surgery. Babies that are born via C-section, there's more complications for the mother and there's more complications for the baby. And so moving forward, we want to address some of those problems. So here we have the socio-ecological model, and I've sort of broken down by level some influential factors that help infant mortality rates drop and ones that also drive infant mortality rates. And as you can see, it's fairly complex. There's a lot of things to consider. Breastfeeding is extremely beneficial in infants and can cut their risk in half as far as infant mortality rates. But we also know that there's a lot of unintended pregnancies happening across the state. We know that pediatricians are a trusted source of information and can really help risk reduction for expectant mothers and teach about prevention of sudden infant death syndrome. But we also know that other people in expectant mothers' lives, like their spouses or partners who maybe aren't supportive of the pregnancy or aren't present, can really trigger some other issues. We know organizationally that it's important to have maternity leave. However, I just mentioned that many of the expectant mothers in Louisiana are on Medicaid, and so they might not be in a position financially or in a workplace that even offers maternity leave. And also babies that are spending a lot of time in childcare centers don't necessarily get the nurturing they need as far as breastfeeding goes, and they're also exposed to infectious diseases. So there's a lot of things to consider when we're looking at this issue. Unfortunately, it is not very cut and dry, but there is a place that we can start. And so I wanted to look at lactation support, prevention of perinatal HIV infection, and progesterone supplementation. And so the important things about each of these interventions is that they are some sort of preventative care. Lactation support, specifically in the form of teaching expectant mothers before they give birth about the benefits of breastfeeding, surveying them and their attitudes towards breastfeeding, and keeping that data close by so that we can then review it after they give birth, after they receive materials and resources. As we know, breastfeeding prevents babies who are breastfed are 50% less likely to experience any sort of infant mortality. So it's important that mothers adhere to that. As far as perinatal HIV infection prevention, we know this is something that we can stop from happening. We know if we know the status of a mother and she adheres to antiretroviral therapy, the baby can be born HIV negative. However, that requires physicians consistently testing high-risk patients and also testing the infant once it is born and making sure that it receives any sort of medical therapy necessary if it is born positive. And as far as progesterone supplementation, we know that progesterone can help prevent spontaneous birth or miscarriage, and that healthy babies are born after 30 weeks 37 weeks, I'm sorry, gestation. And so if I'm sorry, not a pediatrician, if an OBGYN suggests that an expectant mother go on progesterone because she's had a history of miscarriages or premature births in the past, this can really sustain healthier pregnancies, prevent birth defects, things of that nature. And so I just wanted to throw in this little graphic of kind of what our stakeholders look like. I like to say on the left that we have your health educator, your community health activists, your doctors in the middle, and then of course friends and family members who influence the decisions that expectant mothers make are all important to this. And as far as evaluation works, this is really all primarily surveillance data and survey collection. Survey collection more so for lactation support, and surveillance data as far as reviewing the number of babies that are born prematurely, or the number of babies that are born HIV positive, the number of women who find out they're HIV positive upon finding out that they're pregnant. Those data are all the most pertinent to evaluating whether or not the interventions we apply work. Some barriers that I anticipate are just general distrust of medicine and medical personnel, the lack of cultural norming. Less women are breastfeeding these days, less women are afraid of giving birth via cesarean, and some are opting for it. Of course, the general lack of funding. Many of these women do not have insurance of their own, and so are going to be dependent on the state and local funds to provide resources and accessibility. If these classes don't take place in their communities, they might not access them. Here's my logic model to kind of break down the inputs, activities, outputs, and outcomes, and the overall impact. But overall, what we're looking for is improved attitudes around pregnancy, birth, infant health, all of the above. And hopefully that can get us to a place where we're seeing healthier children across the state of Louisiana. Here's my bibliography with any extra resources, and I thank you for your time.